Good afternoon. I'm Hind Tamim, Assistant Professor at Al-Ainy and Consultant at Alfa Lab. Dr. Dina Rasheed, the Alfa Lab Medical Director, deliver her apologies for not being able to join today. I will try to deliver her message about the laboratory medicine in gastroenterology and to show how we provide physicians with high-quality service and decision-making support. Okay. At Alfa Lab, we run a fully integrated service with strong automation and traceability to minimize pre-analytical error. We offer rapid GI-related diagnostic. Our goal to provide faster, reliable results and clinical interpretation support that directly impact physician decisions. We have total lab automation. To reduce total lab automation is to reduce the largest error source, which is the pre-analytical phase. 70% of lab errors happen pre-analytically, not during testing. Automation reduces the delay, improves trust in results, especially for urgent GI bleeding cases and ICU stool request. Total lab automation will help in reducing human factor errors, improve sample traceability, and reduce the turnaround time. Today, I will focus on how the lab contributes across the full patient journey to show the lab is not just confirming diagnosis. It's increasingly shaping decisions, reducing unnecessary endoscopy, and guiding therapy. Let's break down the lab's contribution into 4 key aspects or key areas: screening and prevention, diagnosis, monitoring to follow up, and personalized medicine. Each of these pillars underpins the care provided by clinicians and requires close lab-clinician coordination. The lab is a clinical partner, not test provider, not a passive service. It directly affects patient flow and outcome. GIC symptoms overlap significantly. Lab markers help prioritize who needs urgent endoscopy versus conservative workup. In addition, GI practice is moving toward targeted therapy as biologics, immune-based disease classification, and antibiotic resistance. The lab is central to this because it can improve patient stratification, reduce unnecessary endoscopy, detect silent disease, and monitor relapse objectively. Let's go deep for the first pillar, screening. Screening is where labs save lives because it can detect early in cancer and early diagnosis. For example, FIT for colorectal cancer screening, CBC and ferritin pattern can suggest chronic blood loss before overt bleeding. Viral hepatitis screening is also essential in GI clinics, especially prior to immunosuppression. Quantiferin TB Gold can be useful before starting biologics. Laboratory red flags that should trigger colonoscopy is like microcytic anemia, low ferritin. Tumor markers like CEA are not screening tools, but ferritin and CBC are. Thrombocytosis is often overlooked, but can be a marker of chronic inflammation or malignancy. The lab pattern is more powerful than a single value, positive FIT, and unexplained weight loss. Let's highlight FAT disease, FAT test. FAT is a decision-making tool. It's a powerful triage tool. FAT is not a tumor marker. It's a bleeding marker, but clinically it predicts colorectal pathology very effectively. Why FAT is considered superior to fetal occult blood? Higher sensitivity. FAT is better at detecting small amount of blood in the stool, making it more effective for early cancer detection. Specific to human blood, unlike fecal occult blood, which can react to animal blood from a diet, because FIT uses antibodies specific to human hemoglobin. No dietary medication, no dietary or medication restriction. Patients do not need to restrict the diet or stop medication before taking FIT, which is required for fecal occult blood. It's also better compliance because FIT usually require only one stool sample, while fecal occult blood require 3 consecutive samples, making FIT easier and more appealing for the patient. It's also important for targeted detection because FITs specifically detect the human hemoglobin is more likely to detect the lower rather than the upper GIT bleeding. The second pillar is a diagnosis. Diagnosis where GI clinician faces the most overlap. Diarrhea can be infection, can be inflammatory bowel disease, irritable bowel syndrome, or malabsorption. Liver enzymes elevated may reflect viral hepatitis, autoimmune hepatitis, fatty liver, or drug-induced injury. Lab algorithm help reduce unnecessary procedures and misdiagnosis. FIT has a role in, let's highlight a BioFire in diagnosis. BioFire is especially valuable for immunocompromised patients and in case where clinical feature overlap. It can provide rapid detection of multiple pathogens, useful in severe diarrhea and hospitalized patients, faster than culture, and support antibiotic stewardship. Culture remains useful, but it's slow. Molecular testing offers same-day diagnosis, which is critical for hospitalized patients. The panel with antibiotic resistant also reduces inappropriate antibiotic use. Let's highlight H. pylori molecular testing plus clarithromycin resistant. Clarithromycin resistant is the major cause of treatment failure. PCR moves H. pylori management from empirical to targeted therapy. PCR and H. pylori by PCR can be done on a stool specimen or biopsy, and not only detecting H. pylori, but also detect the clarithromycin-resistant mutations. Multi-TOF mass spectrometry. These systems are used to identify common GIT pathogen from culture, can provide rapid, accurate identification of bacteria, fungi, and anaerobes, including the fastidious anaerobes, often in minutes compared to days for traditional culture. It can identify gut microbiota shifts, such as increased opportunistic enterococcus during severe viral infection, aiding in the diagnosis of dysbiosis. Fecal calprotectin is other test, is a scope decision marker, is one of the strongest examples of the lab medicine guiding endoscopy decision. It reflects intestinal inflammation and especially helpful when symptoms mimic irritable bowel syndrome. It is also useful to monitor response to therapy. Suggested interpretation, 50 microgram or less, IBD is unlikely. From 5,300, it's borderline, recommend to repeat and correlate. More than 350 microgram, inflammation likely, endoscopy is indicated. The third pillar is follow-up, monitoring disease activity and relapse. Monitoring the major strengths of a lab medicine. Endoscopy cannot be repeated frequently, but labs can, so it reduced complication. One of the tests is fecal calprotectin, not only in diagnosis, but also in a follow-up. The inflammatory bowel disease can monitor and predict relapse. CBC simple test as CBC and iron studies can follow a patient with chronic blood loss recovery. Liver function and INR for chronic liver disease progression, and viral load monitoring patients with hepatitis C and hepatitis B. For H. pylori, eradication must be confirmed because symptoms alone are unreliable. So, common clinical mistaken symptoms improve eradicated. Many treatment failure occur because eradication is assumed. The lab prevent recurrence, ulcer relapse, and long-term cancer risk by confirming eradication. Correct approach to avoid false results confirm eradication بعد 4 weeks after treatment, stop proton pump inhibitor 2 weeks before testing. We can use the PCR too to confirm eradication. Especially when resistant guidance is needed, it's also had the privilege that it's less likely to be affected by proton pump inhibitor. The fourth pillar is precision medicine. Precision is to give the right treatment for the right patient at the right time. It is no longer limited to oncology. In GIT practice, for example, resistant testing in H. pylori is precision medicine. Autoimmune liver disease panel are also a form of precision classification. In oncology, molecular testing determines eligibility for targeted therapies and immunotherapy. Precision in GI oncology have now new tumor markers. New tumor markers are molecular markers, not just the serum protein. With these results, guide therapy selection and immunotherapy eligibility. In autoimmune hepatitis, the lab can detect the hidden autoimmune hepatitis. Autoimmune hepatitis is a perfect example where the lab must go beyond basic tests. Some patients have a weak or negative ANA or anti-smooth muscle. Immunoblotting can detect antibodies like soluble liver antigen and other antibodies. IgG is crucial and have a critical clue that can guide to diagnosis. MALDI-TOF plus MIC automation can provide rapid identification plus targeted antibiotic optimization. MALDI-TOF identify organism within a minute after culture. If accompanied by automated MIC support, help in choosing the minimum effective antibiotic dose to reduce resistance and complication. So what to remember? Total lab automation. We have total lab automation that can reduce human errors and improve turnaround time. The 4 pillars and the lab contribution in screening using tests like FIT, CBC, ferritin, rule-in diagnosis that like using BioFire or molecular testing. Therapy selection as H. pylori PCR can detect clarithromycin resistant, its role in the follow-up, and its role in precision medicine. Thank you.